For the bones, this one is the hip bone. It is an irregular bone, and as you know, it is formed by composite 3 different bones together. So we have the ilium here. Okay, this is the pubis, and this is the ischium. Actually, I am holding the bone on the side. The one the bone is the left side bone. So you can see that my thumb and the palm is fitting into this groove. Okay, that's we call it the sciatic notch. Now this above it is whatever you see is the ilium. Whatever you see in the front now is pubis. Whatever you see back is ischium. So ilium, pubis, ischium. Now here, for the ischium we should know one of the very important feature here, that is the ischial tuberosity. This part is ischial tuberosity. Ischial tuberosity is important for us for the name of the muscles we take its origin from here. And that is the hamstring muscles. What are the hamstring muscles? Biceps femoris, semitendinosus, semimembranosus. All these muscles takes its origin from here. There is one more, adductor magnus, but because it's not in our objective, I am telling you to remember 3 main muscles. That is the biceps femoris, semitendinosus, semimembranosus. So this one is the ischial tuberosity. Clear, everyone? Okay. Other part which actually will help you to understand the attachment of the some muscles. This part is known as anterior superior iliac spine. This is the crest. Okay, this is the iliac crest. This is the anterior superior iliac spine. This is the anterior inferior iliac spine. This superior, this inferior. This is anterior, both. Anterior superior, anterior inferior. Anterior superior iliac spine, you have the attachment of this sartorius muscle. Okay, sartorius muscle. While anterior inferior spine, you have the rectus femoris muscle. All muscles will see in the specimen. Okay, but you should know that they are here. Okay. Now here you see this particular joint. Already I discussed in the theory class that there is an auricular surface and there is a tuberosity. This is a sacroiliac joint. This part is the plane because between the auricular surface of the ilium and the sacrum, there is a plane synovial joint. Behind it, this part is the one which is syndesmosis. Okay, it is there in theory class, but ultimately I am showing you where it is here. Clear? So this is what is some of the important facts related to this one. Now see on the outer aspect of the hip bone, you see this big hollow. This particular is acetabulum. Acetabulum is one horseshoe shaped surface and one depression that is known as acetabular fossa. So this particular is acetabulum. Different parts is second story, but at present it is acetabulum. What is the importance of doing this acetabulum? Yes, so with the head of the femur, it will form the hip joint. Okay, this is the hip joint. Okay, what is the type of the hip joint?
Ball and socket.
Ball and socket. So this is the ball and socket joint. Okay, between the acetabulum of the hip bone and the head of the femur. Clear? So this completes as far as the hip bone is concerned and its articulation and important features with some important attachments. Any confusion? Okay, so this finishes as far as hip bone is concerned. We put this aside. Let's go to the femur. Some important features. As I mentioned, there can be very many minute features into it, many attachments into it. What we focus to are related to our joints and some muscles. Okay, so now here, this is the head. Okay, try to confirm with me itself. Okay, so it will be easy for you. So this is the head of the femur. This is the neck, big bones, not small thing like upper limb, carpal like thing, isn't it? So this is the big bone. So this is the head of the femur. This is the neck of the femur. The head of the femur articulates with the acetabulum and forms the hip joint, which we have already discussed. Now comes the neck of the femur. Already we discussed in the presentation that this part is very important in clinical practice to know, because during the old age, usually in female, because of the osteoporosis, okay, when you tumble or fall down or slip, this is one of the very common fracture. We call it fractured neck femur. Okay, fracture of the neck of the femur. And one of the specimen here has the artificial, there is a hip replacement surgery is done. So you can see the steel ball in that particular body. Okay, I'll show you also. But this is what is as far as the neck of the femur, its clinical importance. Clear to everyone? Let's go to another feature in the upper end. You see this part, I'm showing you this one is the greater trochanter. And this is lesser trochanter. Trochanters are massive, big, okay, and they are larger than, actually we call it tuberosity also. So this is large, so we call it greater trochanter. This one is little smaller compared to this one. We call it lesser trochanter. Both are trochanters. The muscles attached to the trochanters are not objectives for this particular lecture or the lab. But if you see the hip joint and the movements of hip joint, the names of those muscles are still there. So names you should know. That this here you will find gluteal muscles. Okay. And here lesser trochanter you will find psoas muscle, psoas major. Why you want to know this? You don't remember as a lab, I tell you. But if you theory, if you read, you have to know that this muscle is the extensor of the hip. If you see the hip joint and movements, extensor of the hip is here, and the flexor of the hip is here, psoas. So this is the flexion, and this is the extension. I'm talking of thigh, isn't it? This is the flexion of the thigh, this is extension. So the extension is done by gluteal muscles, back. And the muscle which is in front, this one, is psoas, okay? And it was responsible for flexion. Okay, so this is what is the two important group of muscles in these two features. That's why we ask you to remember that where is greater trochanter, where is lesser trochanter. Because of this relevance. Okay, so this finish is apparent. There are many other features, but this is the one which is relevant to our topic. Goes to the now to the shaft. Okay, if you touch the shaft all around, it will form smooth. Okay, but if you touch the posterior part, how do you know it's posterior? Look at the lower end, you find a notch here. Okay, notch between two condyles is posterior. So just above it, if you move your fingers, you can feel a rough line, rough. Okay, compared to all others, everything is smooth. This is rough. Because of this roughness, we call it line, which is rough. Rough is asparagus. Okay, asparagus is rough. And line, linea. Linea aspera. Linea aspera is the name of this line. Why it is rough? Because it gives attachment to many muscles. Okay, because of the pull of the muscle, this bone will develop here, extra bone, isn't it? And that's how you will find roughness of this particular line. What are the important muscles? Technically is theory. That vastus medialis, vastus lateralis, adductor longus, biceps femoris, short head. So there are many. Okay, but what my concern for you to know is that the linea aspera is a rough line on the posterior surface of the shaft for the attachment of the muscles. Okay, so this is what is about the shaft. Clear to shaft? Anyone has any confusion? Okay, let's go to the lower end. Lower end is very simple. There are two condyles. Okay, head is medially. So in the line of the head, it is the middle condyle. In the line of the trochanter, lateral condyle. So you will not make mistake for the medial and lateral condyle. This is the medial condyle, this is lateral condyle. Clear? Between two condyles, if you see posteriorly, there is a notch. Between, inter, condyle, condylar, notch. So intercondylar notch. Okay, this is intercondylar notch. This condyles, now we come to the joint, next joint from here to here, isn't it? Now my logical sequence is clear to you. That, so here we will have a knee joint. Is it clear? So these femoral condyles will join with the tibial condyles, this is tibial condyles, and form the knee joint. Okay, the anterior part of the condyles here also has attachment to or articulation to the patella, kneecap. Okay, so this is patellofemoral joint, and this is the tibiofemoral joint. Ultimately, composite is the knee joint. When you move the knee, your kneecap also will move up and down. Okay, so it's a composite movement together. So this is what is about the here the condyles taking part in the formation of knee joint. Clear up to this point? So this finishes as far as the important features of femur is concerned. Any confusion in these names? Next, the bones of the leg, isn't it? So there are two bones in the leg, one tibia and one fibula. Okay, so we have two bones, one tibia and one fibula, isn't it? So tibia is the one which you can see also, isn't it? Model. The tibia is medial and fibula is lateral. Clear? So tibia is medial bone and fibula is lateral bone. The Tibia corresponds to radius actually of upper limb. But if you see upper limb, radius is lateral and tibia is medial. Fibula is medial in the upper limb. The ulna is medial in the upper limb, while fibula is lateral in the lower limb. Because of embryological reverse rotations of upper limb and lower limb, arrangement is reversed, okay, in the upper and lower limb. That's why even the corresponding bones is having different arrangement. Clear? Same way the muscles. If you see the muscles of the arm, here in the front you find flexors and here you find extensor, isn't it? Triceps is extensor and biceps is flexor. If you see now lower limb, here the front muscle is extensor and the back muscle, which is biceps and others, are flexors. Okay? So flexors are on the back and extensors are on the front, exactly opposite to the upper limb. Got it? Because of reverse rotation of embryological development. Okay? So this is what is as far as one of the corresponding upper and lower limb is concerned. Now we go back to the each bone. So here you see the tibia has upper end. We call it condyles. Then the shaft, and then the lower end. Lower end has a pointed part. We call it malleolus. This point. It looks like a styloid process of radius, isn't it? But styloid process is smaller. This is bigger. So we call it malleolus. Okay. So this is medial malleolus. Okay. And this one is the shaft, and this one is the upper end. If you see the upper end is condyles. Between two condyles, you find elevation. So again, the word will be intercondylar eminence. Eminence is elevation. Eminence is another word to look like same elevation. So this is intercondylar eminence or intercondylar elevation. It is between two condyles. So when the femur fits into it, this condyle will be actually this between the intercondylar notch. There is a notch, here is elevation. So it's corresponding. Okay. And this is how ultimately they will fit in. Why I want you to know these things is because in future when we will be advanced years, all ligaments which I will discuss, the knee joint, all ligaments has attachment here in this region. Okay, that's why we should know. So during arthroplasty of the knee joint, you are repairing knee joint, you will enter into this region to repair. That's why all people ask you to memorize that this region is intercondylar region and where you will find attachment of cruciates and menisci. Clear? So this is upper end finish. Okay. Now here you see just below the condyle, this region. There is a tuberosity. Okay, this tuberosity. Bone is tibia, so name is tibial tuberosity. Like radius, radial tuberosity. Here this is tibial tuberosity. Clear? So this one is tibial tuberosity. Tibial tuberosity receives the tendon of the quadriceps after patella. Okay, so this one is the insertion of actually quadriceps through patella to the tibial tuberosity. Okay, so that is a patellar tendon. Patellar, isn't it? Patellar tendon. So patellar tendon is attached to the tibial tuberosity. So this is another important feature we should know because we know the ligament of the knee, patellar ligament. It is the tendon of the quadriceps. We know the quadriceps muscles. So we should know this tuberosity. Clear? So this is what is in the upper end. Apart from this upper end will receive the attachment of some muscles from the thigh also, isn't it? Apart from patellar tendon. Like I told you for the upper limb, that triceps goes to ulna and biceps goes to radius, isn't it? I told you in upper limb. Same you can remember in the lower limb, that the biceps goes to the fibula. Okay, so biceps femoris goes to the fibula, fibular head. Okay, while semimembranosus and semitendinosus, they are the muscles on the back, isn't it? I'm talking about muscles on the back. Front I already finished, tibial tuberosity. On the back, they go to tibia. Okay, so biceps femoris to fibula and semitendinosus, semimembranosus to tibia. Then you can say that which one in which part. Usually they are on medial surface and medial condyle. Okay, and here on the head. Clear? So this is what is about the upper end of this bone, shaft. As I mentioned, shaft also must be having muscles. Usually you should remember that these muscles will be related to tibia, tibialis. Tibialis anterior, tibialis posterior, tibia, word same, isn't it? So these muscles will take origin from tibia. These are the two muscles which we discussed in the lecture, if you remember. Tibialis anterior, tibialis posterior. But they will come from tibia. Okay. One more thing is that tibia and fibula both together gives usually the attachment of one of the very important muscle of the back of the leg. We call it soleus. Each muscle you will see, but I'm just telling you to remember the bone. But where we don't expect too much, but you'll see that it is from tibia and fibula together. This area, whole area. Okay, so that is for the soleus. Soleus is a big muscle of the back of the leg, calf muscle. Okay, so this whole thing is soleus. So this is attachment on the tibia and fibula, shaft. Lower end, malleolus. Lower end is known as malleolus. Medial malleolus because it's a medial side. Lateral malleolus because it's lateral side. Okay, so we have medial malleolus formed by tibia and lateral malleolus formed by fibula. So we finish the tibia and fibula together now. This one is head of the fibula, upper end. This is shaft of fibula, and this is the lateral malleolus. Clear? Now here I already mentioned what is the attachment? Biceps femoris. Here shaft. Do remember that's a lateral bone. So most of the muscle is from lateral compartment. Okay, like peroneal muscles. Peroneus longus, peroneus brevis. They are from the fibula. Got it? So if you logically understand, each attachment is very simple. Based on the name and arrangement, if you remember. It's lateral compartment. Which bone lateral? Fibula. So that means the peroneal muscles which are lateral should come from fibula. Okay, and this is lateral malleolus. Why we should know the lateral malleolus and the medial malleolus is because it is both the bones, isn't it? Tibia, fibula. So I want you to know now here, this is, isn't it? So now we go down up to this. Here syndesmosis, everyone knows now. By example, between tibia, fibula or between radius ulna, there is a syndesmosis here. There is a plane joint here. Now we are here, isn't it? Two malleoli. So I'm in the last part of it. That this is the two malleoli together with the body of talus, ankle joint. Okay, so you should remember that lower end of tibia and lower end of fibula together, lower end of tibia and lower of fibula together forms a socket for the body of talus to form the ankle joint. Okay, so it is hinge joint. You cannot do any other movement than this because there is two big bones restricting it, isn't it? So you have plantar flexion, dorsiflexion, plantar flexion, dorsiflexion. That is at the ankle joint. Ankle is a hinge joint. Clear? So we will show you which muscle does it, but ultimately this is what is the action at the ankle joint. And how it is formed between these two bones. There is a malleoli of the tibia and fibula and the body of talus. This is the talus. Okay. Now we should know the foot, isn't it? Already I mentioned in the here tibia flexion extension, but there is slight rotation also, as I mentioned in my lecture, that there is slight medial rotation and lateral rotation. Okay, that is locking and unlocking of the knee. Once I finish this, as far as bones are concerned, I will show you in a few minutes about with the bones how it moves. So you will understand what that locking is. Okay, but we finish this part and then we'll go back to the bones, and there are again some detail aspects. But this is about the foot now. Clear? So let's see the foot, and there are bones and some another joint, ankle, and now going further. Okay, this is the foot. Okay, now we should know which are the bones of the foot. Okay, so when you close by, try to identify each bone. It is still bigger than the carpals, easy to identify. So this one is the calcaneum. This one is calcaneum. Just on the top of the calcaneum, you see this one. Okay, this one is the talus. Body of talus, but it is talus. Talus is a body, neck and the head. But this is a talus. So this talus, this is calcaneum. If you see the talus like this, okay, talus, in front of the talus, you see a boat shape. We call it navicular. Navy means boat, isn't it? Navicular. So this one is the navicular. In front of the navicular, you find three bones. Okay. All three are wedge shaped. You understand wedge shape? Okay. Wide at one point, pointed at another. Wedge shape. So these bones are pointed down and wider upper part. So we call it cuneiform. Cuneiform. Cuneiform means wedge. Cuneiform is leading over for the wedge. So cuneiform. So there are three cuneiforms. Medial, intermediate, lateral cuneiform. Even remember, you should know that there are three cuneiforms. Clear? And then still lateral to it, you will find a cube-like bone. We call it cuboid. Cuboid. So if you see from the top view, you can see all bones together like this. Calcaneum, calcaneum, talus, navicular, 1, 2, 3 cuneiforms and cuboid. Total 7. One less than the upper limb. Okay. So this finishes the tarsals. Clear to everyone? It is easy to remember also and easy to identify also, not complex. Then you see the metatarsals. First is very strong, very taut, okay, and then you see second, third, fourth and fifth, okay. So these are the metatarsals. Then comes the phalanges, 2 for the first and the rest of the 4 has 3, total 14. Okay, so this finishes as far as the bones are concerned. One joint which remained here is the subtarsal joint or talocalcaneo-navicular joint. See the names, talo, talus, calcaneo, calcaneum, navicular, navicular, talocalcaneo-navicular joint. Where is it? This talus, this navicular, this is calcaneum. So it is here. It is combined joint. Okay, so it is very easy to interpret that it is between talus, navicular and cuneiform. Okay, so this is the talocalcaneo-navicular joint. This joint is important for us to know because one of the movements of the foot is still remaining for us to understand, that is known as inversion and eversion. Inversion is very large, isn't it? You can do more compared to eversion. Eversion is less. Okay, so inversion and eversion. So inversion and eversion takes place at subtalar or talocalcaneo-navicular joint. So in nutshell, I finished all the joints, all the bones and all different movements taking place at different joints. Isn't it, up to the inversion and eversion? Plantar flexion, dorsiflexion, flexion, extension, medial lateral rotation of knee, and then flexion, extension, abduction, adduction, medial rotation, lateral rotation and circumduction of the hip. Got it? So this is the organization in your mind, that where you start and where you finish. Clear? Up to this point is clear to everyone? Knee is a hinge, but if you are trying to stand or start motion, or your foot is off the ground, you can still rotate it, okay, medial or lateral. That's why some people consider it condylar joint, okay. So this is debate between different type of thought process. For you level, you can keep either a hinge or condylar. For me, no problem, you can write hinge functionally, condylar structurally, okay. But here, how it does flexion extension. So you understand that what is flexion extension, isn't it? This is the joint. This flexion is extension. Okay. I do reverse now. This is flexion. This extension. Correct or not? Flexion, extension. So either I do like this, flexion, extension. Isn't this flexion of the knee an extension of the knee? No, I will do like this. Flexion, extension. Because when you are standing from sitting to standing, still the reverse, it is still extension, isn't it? Okay, so your mind should understand in all perspective, that not just this way only. Because we sit down and we stand up also, isn't it? So that is the same time action will be taken, isn't it? So I am doing this way. That suppose you are standing from the sitting posture, so this is the position, isn't it? And this is the extension taking place. Femur is moving, and this is fixed. Okay, so just try to see what I am doing. This is the last part of extension now. Okay, now last part of extension. There is slight rotation of medially, lateral, and then flexion starts. I'll do again. Smaller things, isn't it? See the way these tibial femoral condyles rotate on tibia. This is straight, up to this table straight. See, this is twisted now. Then I have to retwist again. Then start the flexion. So, when you are from here trying to stand up, when you finish the terminal part of the movement, last part of the extension, and do this way. Lock, isn't it, the knee? So then what you will find, that all ligaments are tight and all muscles are free. Okay, so you can stand for maybe 1 hour, 2 hours, 3 hours without using the muscles, because knee is locked by the ligamental twist this way. Okay, this is the twisting. We call it locking of the knee. So locking it doesn't need the muscle force. Okay. But like you have the auto locks. You know auto locks means what? There is a lock by which you can press it. Okay, press it and it locks, isn't it? No need to key to lock, isn't it? We have locks which press it and it locks, isn't it? So it is like this. So that here, this particular part, it's by the articular surface of the femur, it glides on the tibia and locks. Okay, so for that you don't need any muscular force. Okay, but to open it, unlock, any lock you locked it, now it will not open by any means except you insert the key. So unlocking needs a key. Locking doesn't need the key always, but unlocking necessarily need a key. That means I need somebody who can unlock my knee to start my flexion. Okay, so there is a muscle which is from the back here, which is not your objective as far as theory is concerned, but as far as knee joint is concerned, I want you to know that there is a muscle on the back. So when this is locked like this, okay, there is a muscle which makes a jerk. Okay, so it causes lateral rotation. That small muscle is known as Popliteus. Popliteus on the back. It is like this on the back. And it pulls the bone. Okay, so from the back. So that now knee is unlocked. Then flexion will go. Again extension, terminal extension, rotation and lock. Again unlocking, I need a muscle. Then it will further flexion. Clear? This is locking and unlocking. This mechanism you will remember for long till you pass out and graduate, and if you join orthopedics throughout life. Okay, because this locking and unlocking mechanism is very important for the knee joint and all future surgeries for the knee joint, injuries of the knee joint. Clear? So you start with the hip, isn't it? In this model we have the for the hip. Now I am putting it this way. Okay, so this is the front, this is the back. Whatever is facing to you is the front. What you see is this the pubis, isn't it? This is the pubis. So from pubis to femur, tubofemoral ligament, theory, tubofemoral ligament from ilium. This is the ilium. From ilium to femur, iliofemoral ligament. So this is pubofemoral, iliofemoral ligament. I am turning back. Now posterior. Posteriorly you see this ischium. Ischium. You have to identify parts, isn't it? Ischium. From ischium to femur. Ischiofemoral ligament, three main ligaments, there are many I mentioned, but ultimately three main which you can see always and it's to be remembered is the ischiofemoral ligament. So ischiofemoral ligament, tubofemoral ligament, iliofemoral ligament. Okay, all the three ligaments of the hip is here in this model. So you can see them, they are holding all around it, isn't it? And the strengthening the hip joint. As far as the knee joint is concerned, see this one. There was here the patellar ligament which is there in the model which I will show you. So patellar ligament is here like this. Okay, from patella. This is a patellar ligament. Okay, so this is the here. This is the quadriceps tendon coming up. This is the patella. From patella to the tibial tuberosity, as you are asking, isn't it? So this is the patellar tendon. Patellar tendon is also included as a patellar ligament for ligaments of knee joint. So it's a tendon of one muscle and acting as a ligament for another joint. Okay, because it's very strong. So this is the patellar tendon, also known as patellar ligament. Both name is correct. Clear? So this is what is the patellar ligament. Now you can see that there are collateral ligaments, isn't it? This one is the medial, that is tibial collateral ligament. This one is lateral, fibula, lateral. So this is the fibular collateral ligament. Now you see, in the cavity there is a meniscus, isn't it? Meniscus. You can observe that this particular tibial collateral ligament is flat, while fibular collateral ligament is cord-like. Second fact, that tibial collateral ligament is attached to the medial meniscus. See, it is closely attached to it. See the fibular collateral ligament? Yeah, see? So lateral meniscus is free from the fibular collateral ligament. Clear? So that means when there will be injury, sports injury, where you are abduction injury, when you are running and suddenly foot is trapped up, then there will be injury to the tibial collateral ligament also, and there can be injury to the medial meniscus also. Okay, so this too is clear to you. Why medial meniscus is commonly injured? Because it is unable to escape itself from the joint when there is a force, because tibial collateral ligament pushes it into inside, isn't it? While the lateral meniscus will not be trapped because it's free, it can move. Okay, and some of the fibers of Popliteus are attached to it. So when the joint is moving, the muscle is also acting. So meniscus is always moving out and in, out and in. So when sudden force comes up, the muscle will contract, and this meniscus will be outside, means away from the joint between the bones. So it will be safe. While this one cannot move out, so it will be trapped. So that's why you will find medial meniscal tear more commonly in the knee joint injuries. Okay, so this finishes the two collaterals. Now I'm talking on the two menisci and lastly the cruciate. Okay, two menisci are the Fibrocartilage disc. I already mentioned it divides the cavity into two compartments. It makes the surface congruent. See, tibia was flat, now it is fuller, isn't it? So the femur condyle can easily fit into it. So this is what is its function. It makes surface congruent. Congruent means matching to the other bone. You can see that this one is lateral, this one is medial, isn't it? Medial malleolus, medial. So if you see two menisci shape, the medial is semilunar, C shape. Okay, while the lateral meniscus, this one, is circular or O shape or oval, you can call it, either way it's correct. Okay, so this is the shape of two menisci. Clear to everyone? And as I mentioned, medial meniscus is more prone to injury. Okay, now let's go to the cruciate. Cruciate means cross line. Okay, so we need to see cross. If you see this way, that inside there is a ligament which is going from front to back, and there is a ligament which is coming from back to front. Okay, there are two ligaments. So this from back, isn't it? And then this is from front. Okay, the names of the cruciate ligament is based on their attachment of the tibia. If this is originating from tibia anteriorly, we call it anterior cruciate ligament. This one is originating from posterior part of tibia. So this one, posterior, isn't it? So we call it posterior cruciate ligament. So this posterior cruciate ligament is anterior cruciate ligament. Anterior runs backwards from front, and posterior will run forwards from back, isn't it? And they are crossing each other, but they are not attached to each other. They are separate ligaments, but they are crossing their directions, opposite directions. So they are maintaining antero-posterior stability of the knee joint. These two ligament collaterals will maintain side-to-side stability of the knee joint, and menisci maintain the congruency of the knee joint. Okay, all three has different functions. So what I mean by antero-posterior stability of knee joint is this, that this particular ligaments maintain this tibia in such a way that it will not move this way. Okay, it will allow flexion extension, but it will not allow abnormal movements front and back like this. Okay, so if there is an anticruciate ligament torn, then the tibia will move abnormally in front. Okay, because the ligament which is coming from front is not able to hold it. If the ligament from the back is posterior cruciate ligament torn, then you can move the tibia backwards. This is a clinical test we do for ligamental tears. So when I examine the patient and I try to move the tibia, if I can move it forwards, I am sure that it has anticruciate tear. We call ACL tear, ACL, anterior cruciate ligament tear. If it is moving backwards, I know that it is posterior cruciate ligament tear. Okay. Now ACL is very common word, isn't it? I did not speak so common PCL, isn't it? Why? I am telling you the fact that when the injury is there in the knee joint, there is an unhappy triad of knee. It is formed by combination of three things. One, the tibial collateral ligament. Okay. The second, the medial meniscus will be torn. This side, medial meniscus will be torn. And third, anterior cruciate ligament will be torn. All these three things together is known as unhappy triad of the knee. Clear? So this is what is about the cruciate ligament and their importance. And the complete all three together, importance of collateral, importance of menisci, importance of cruciate. And injury, usually as I mentioned, tibial collateral, medial meniscus and the anticruciate combined. But if force is more, nowadays people driving at 260 kilometers per hour speed, maybe stuck up in accident here and there. Do you think that only slight tear will be there here and there? Multiple injuries. So that's why you will find, other than what normally once upon a time clinician used to find injuries, you find more complex injuries, and you have to repair all different complex injuries. So this is all about as far as some of the important ligaments, bone and joint are concerned. Clear to everyone? Finish this part.